you so very, very much for the introduction and for the invitation to be here with you today. Like my predecessors on the podium, I couldn't resist the invitation to come here again to be with my friends and colleagues here in Bangkok after so many years, and it's truly wonderful to see everybody. We're going to be talking about a different virus for the next little while, which is HPV, also a syndemic. It seems to be a pretty popular term these days. And I'm going to be talking about a cancer which some of you may not be that familiar with, but which is growing in importance, and that is anal cancer. And I'm going to be talking about screening and early treatment for this disease, evidence from a recently published study called the ANCRE study, and what it means for Asia. These are my disclosures. And what I'd like to do is talk with you about the risk of anal cancer in people living with HIV, understand the results of the ANCRE study, and understand the implications of the study for research and clinical practice in the Asia-Pacific region. So one of the reasons why you may not be familiar with anal cancer is that it's a relatively uncommon cancer. It is certainly much less common than cervical cancer. However, while it is relatively uncommon in the general population, it is known to be particularly common in certain risk groups shown on this graph from a meta-analysis from ANCRE. Before I talk about the risk in different groups, I want to point out that anal cancer is a horrible disease. This is a disease that spreads locally through the lower pelvis and metastasizes. And the good news is it is often caught at an early stage, and when treated at an early stage, it's often successful. So the survival rate is good. So you may wonder, what is the big deal? The big deal is that for somebody to survive that early treatment, they need typically chemoradiation therapy. And chemoradiation therapy is highly morbid. It essentially ruins most people's lives. So while they may survive their cancer, they suffer from years of pain, bleeding, psychological dysfunctions, sexual dysfunction. You do not want to get this cancer, and if there's anything we can do to prevent it, that would be for the better. So having said all that, there are, as I mentioned, certain risk groups that are known to be at particularly high risk of this disease, and they're shown on this slide. The three leftmost columns are people with HIV. They are men who have sex with men who have HIV, males who are not MSM living with HIV, and women. One thing you'll also notice is that the risk is increased as a function of age. So the older you are within any of these groups, the higher the risk of cancer. This is the risk in the general population, and just to put this in context, in the United States, for example, the risk of cervical cancer in a largely screened population is on the order of about 6 to 8 per 100,000 women per year. And you can see here that we're in much higher levels for all of these groups. In addition to people living with HIV, there are two other major groups. They include women who aren't necessarily immunocompromised, but who may have had an HPV-related cancer elsewhere in the genital tract, mostly the cervix and the vulva, or their precancerous lesions, high-grade squamous intraepithelial lesions, or HSIL, and also people who are immunocompromised for reasons other than HIV. And what you see here is that the risk goes up, not as a function of age per se, but rather years post-immunosuppression. So it is possible that some of the age effects that we see here in people with HIV actually reflects combination of aging, because we know certain things happen with aging to the immune system, etc., but also potentially the duration of immune suppression associated with being older. What do we know about anal cancer in Thailand? What we can see here from WHO data is that, like in many other countries, it is an uncommon cancer in the general population. Something we see in virtually every country is this very substantial age-related increase in incidence. So this is very typical. One thing that is a bit unusual about what we see in Thailand compared with most countries, say in Europe and North America, is that in those places, the incidence of anal cancer is higher in women than it is in men. Here it seems to be much closer, and in fact maybe a little bit higher in men than in women, and I don't really know why that's the case. Now, as I mentioned, these cancers have a precancerous lesion known as HSIL, and these are all associated with HPV. So if we want to have an understanding of the risk of anal cancer going forward, it's important to understand the prevalence of HPV, in this case anal HPV, and HSIL, in this case anal HSIL, in populations at risk. And I'm pleased to say that this group, ANCRE, the Asian Neoplasia Study in Asia and the Pacific, was probably the first group in the Asia-Pacific region to start in on this problem, and I had the privilege of working with them. This is work that we've been doing together since 2014. Dr. Prapan, Dr. Nitaya, many of the group here, and we essentially work together to train people in some of the basic techniques needed to do this kind of work, including getting skills in the equivalence of cervical colposcopy, known as high-resolution anoscopy, that allows the clinician to use the gold standard method to diagnose cancer and precancer using anoscopically guided biopsies, so the gold standard being histology. So the work that this group did actually is, again, most of what I think is in the literature at this point. And I thought it was interesting to go back to one of the presentations that I gave in 2015 when I was here to try and help set the agenda for the group and thinking about what kind of data we would need. And again, what I thought was going to be important was defining the prevalence and incidence of anal HPV infection in the at-risk groups, particularly people with HIV, understanding if the spectrum of HPV types is the same here or different from what we see in other locations, and also defining the prevalence and incidence of the cancer precursor lesions in these at-risk groups. So the group has been quite productive, actually, and has published multiple papers. I'm just showing a little bit of data here, but want to point out that, as in many other countries, the prevalence of oncogenic HPV is very high in MSM living with HIV, and it's also high in HIV-negative MSM, but there is a statistically significant difference. Again, the prevalence of HPV that we see here is quite similar to what we see in other MSM populations, both HIV positive and negative, in other parts of the world. And this was work done in Indonesia, Thailand, and Malaysia. Ultimately, it's the disease that hurts the people, and so understanding the prevalence of HSIL is very important. And this was a study published by Nitaya, Panupak, and colleagues, and showed in a group of MSM living with HIV and HIV-negative MSM that the prevalence of HSIL was about 19% in the folks living with HIV and lower at 11% in HIV-negative MSM. Now, these numbers may seem smallish to you, and by our standards, at least in the United States, the prevalence of HSIL is lower than what we typically see. But again, I want to put this in the context of what you see in the cervical world. If we were to randomly sample 100 women walking around Bangkok right now, we would find, assuming that they're healthy, that fewer than 1% would have a cervical HSIL lesion. So even though these numbers are smaller than what we typically see in the United States, they are very high in terms of potential cancer risk. Moreover, what is concerning here is the high incidence of HSIL in these populations, 29% and 8% respectively in positive and negative MSM. So that one-time sampling showing 19 and 11% was high, but probably would go higher with repeated sampling over time. So this all begs the question, what can we do about this? Can anal cancer actually be prevented? And the reason we think this is possible is because of our assertion that cervical and anal cancer are very similar diseases. They are both associated with HPV, predominantly HPV-16. We know that cervical cancer is preceded by this lesion, cervical HSIL here, which, if left alone, progresses to invasive cancer over time in a high proportion of women. and we see the very same lesion in the anus, and we know from natural history studies that anal HSIL is the precursor lesion to anal cancer. So why haven't we been doing prevention strategies like have been already well established in the cervix? And the answer is primarily that we live in the era of evidence-based medicine. And while we know that it works in the cervix, and that is based actually not on any clinical trials, but on decades and decades of experience and observation, we know that where prevention programs have been set up, consisting of screening for cervical HSIL, typically with a cytology, followed by biopsy proof of cervical HSIL, and then physical removal to prevent progression, we know that that works because we've seen it happen over time. However, now that we're in the era of evidence-based medicine, that's not good enough to say, well, of course it's going to work in the anus, we should just do it. And so that study is what I'm going to be describing to you next. We needed to know whether it would work to decide whether or not it was worthwhile to try and institute a prevention program for anal cancer. So we did a study called the ANCRE study, supported by the U.S. National Cancer Institute. ANCRE is an acronym that stands for Anal Cancer HSIL Outcomes Research Study. And this was a study of the AIDS Malignancy Consortium. And the results of this study were published in New England Journal last June, and this is shown here. You might guess from this that, in fact, treatment was shown to reduce the incidence of anal cancer, and you would be right, otherwise I wouldn't be standing here talking about it. We had 4 aims of this study. The first was to determine whether treating anal HSIL is effective in reducing the incidence of anal cancer. And you may say, of course it is, it works in the cervix. You're saying it's the same disease as in the anus, of course it's gonna work. It was not actually obvious. And the reason is because treatment of cervical HSIL doesn't work all the time either. And when it fails, it's typically because the woman is either immunocompromised or has very large lesions, exactly the situation that we see in people living with HIV in the anus. So it was not a foregone conclusion that treating these lesions would work. The second was to determine the safety of treatments, because this is a preventive measure, and the treatment bar for a prevention program is, the safety bar is going to be very, very high. The third was to assess people's quality of life. We're doing things to them. Some of them are not entirely comfortable. We want to know whether those procedures are acceptable, because even if they're effective, if the participant or the patient doesn't like them, then it's not going to be an effective preventive measure. And then the fourth, very importantly also, was to create a biobank of specimens collected from people in the study as we followed them, in particular to determine the molecular pathogenesis of progression from high-grade disease to cancer. In fact, our very last opportunity to do this kind of experiment, you cannot do that in the cervix anymore because it's standard of care to treat cervical high-grade disease. The other major HPV-related cancer, which is head and neck cancer, we don't have a well-defined precancerous state. And so this study provided us an opportunity to follow people diagnosed with high-grade disease, some of whom progressed to cancer, some of whom didn't, and gives us the opportunity to try and understand what happened along the way. So the study schema is shown here. To get into the study, you needed to be 35 years or older, living with HIV, and have biopsy-proven high-grade disease. If you didn't have high-grade disease, you weren't enrolled in the study then, you might have been rescreened later in case you developed that later. Or if you had cancer, of course you were not enrolled in the study, you were referred immediately for cancer treatment. But we did end up enrolling a large number of individuals who had biopsy-proven high-grade disease and who met the other study criteria, randomized them 50-50 to treatment versus what we call, perhaps a little euphemistically, active monitoring, basically watching them very carefully for signs of progression to cancer, but not treating them. And then we counted up the number of cases of cancer in both arms and reported that to the Data and Safety Monitoring Board. Now this was a big study, and we estimated that we would need to enroll and follow 5,058 individuals living with HIV. And to get that number, we estimated we would need to screen more than 17,000 such individuals. And so we did the study in many sites around the United States. This was an event-driven analysis where the primary outcome was time to cancer. And we estimated to achieve the power that we were looking for that we would need to detect 31 anal cancers. And so when we reached that threshold, we reported the data by arm to the Data and Safety Monitoring Board. Now, the half of the group that were randomized to treatment, they were allowed to be treated, but only from a menu of treatments that were available to the clinicians, primarily ablative measures and a few topical options. And then if they picked one of those, they had to follow a treatment-specific algorithm. So they couldn't just treat with any method they wanted. They had to pick from our menu, and they had to do it the same way that we told them to, using a well-defined treatment algorithm. They were allowed to be biopsied anytime there was any concern for cancer. They were typically followed every 6 months, or more often until their HSIL was gone. And they could be seen as early as every 3 months if necessary. In the active monitoring arm, it was very similar. They were typically followed every 6 months, could be seen every 3, biopsied any time, but basically they were only biopsied routinely as a matter of protocol every year to avoid the risk of over-biopsying and potentially inadvertently treating someone by repeatedly removing more and more of a lesion over time. So what ended up happening was a bit of a surprise to us because we had made certain assumptions about the progression rate from high-grade disease to cancer. And in fact, we were off. The progression rate is quite a bit higher than we had originally projected. And we reached our case count even before we finished enrolling the 5,058 people. We ended up enrolling and following 4,446 people, and to find them, we screened 10,723 people. I thought you might be interested to see the prevalence of HSIL at screening. What we found was HSIL in 53% of the men at screening, 47% of the women, and 67% of transgender individuals. In previous studies, it seemed as though the prevalence of HSIL was quite a bit lower in women than in men. We did a study in the AIDS Malignancy Consortium a few years earlier and found HSIL in 28% of the women. Here we found it in 47%, so they're not very far behind the men, if you'll pardon the expression. And so what I'm really telling you is that the cancer precursor is enormously prevalent. Again, remember, cervical HSIL in a healthy population of women typically found in less than 1% of women. When you screen 10,000 plus people, you also expect to find some cancers, and we did. In fact, we found 17 cancers. These were all asymptomatic people. They were referred for therapy, and that resulted in a point prevalence estimate of 160 per 100,000 people. We aimed to try and get a population that was reasonably representative of the overall US HIV population. All of these demographics have been published. I just want to point out a few things. One is that the median age was 51 years in both of the arms. And these individuals were out after original HIV diagnosis of 17 years. So these are people who have been positive for HIV for quite a long time. We had 80% men and 16% women, 3.1% transgender people. And our racial ethnic background actually pretty closely resembled what we see in the US. About a third are non-Hispanic white, 42% African American, 15% were non-African American Hispanic, and 1.3% were Asian Pacific Islander. They were also predominantly listing same-sex activity as their HIV risk group. And it was also interesting that from an HIV point of view, they were actually very well controlled. The median CD4 count at screening was over 600. Almost everybody had a low or undetectable viral load. So despite the fact that we had all this HSIL, people's HIV was very well controlled. Also, alarmingly, about a third of the population were active smokers. That's good news, bad news, because that's one of the few factors that we actually potentially have some ability to modulate. And then we also stratified our data by the lesion size for the reason I mentioned before. About 12% of the population had lesions comprising more than 1/2 of the anus and perianal area, and about half of the population had a nadir CD4 of below 500. So although the study was not designed to compare different treatments, remember they could pick from the menu, we were lucky because almost everybody picked one treatment, and that was office-based electrocautery. The technique we use the most is called hyfurcation. It's a very easy technique to do in the office, doesn't take very long, does not cause a lot of pain. Some people get up and go right to work. It is not like sending a patient to surgery. And so not only did most people have that treatment, but most people only had that treatment. And so whatever benefits we saw in the study, we thought could potentially be attributable to primarily office-based hyfurcation. We ended up reporting to the DSMB on 30 cases. A couple were disqualified because they were diagnosed with anal cancer prior to randomization. And the bottom line, again, if you'll pardon the expression, was that there was a 57% reduction in anal cancer in the treatment arm compared to the monitoring arm. And you can see here the progression rates were very high in both arms, a lot higher in the monitoring arm, 402 per 100,000 person years of progression from high-grade disease to cancer compared to 173 in the treatment arm. So a pretty good delta, but a little disappointing because I would have liked it if we'd had even lower cancer rates in the treatment arm. These are the Kaplan-Meier curves showing the widening gap between the two arms over time. And the other piece of good news is that the treatments were very well tolerated. We had an extremely low adverse event rate and only 7 study-related serious adverse events, despite having done thousands and thousands of procedures, and these resolved relatively quickly. So the Data and Safety Monitoring Board recommended we stop the study for efficacy and offer treatment to everybody who was previously in the monitoring arm, and which we are doing now, as well as continuing to follow people who were in the treatment arm before. So the implications of the study are that the rates of progression from anal HSIL to cancer are high, in fact, double what we had originally estimated from the literature. We do show that treatment of anal HSIL is effective in reducing the incidence of anal cancer. And as we speak, the Centers for Disease Control are reviewing revised guidelines for the care of people with HIV, opportunistic infections and disease. I can't know for sure if they will accept those guidelines, but if they do, the screening for and treating anal HSIL will become standard of care for people living with HIV. Also, we are very pleased that the U.S. Preventive Services Task Force took up anal cancer screening as a priority topic, and the first level of public commenting just ended a few days ago. So for the short term, we are recommending that everybody have a digital anorectal exam. That is a no-brainer. We all know how to do it. You can pick up early cancers by putting your finger in and feeling for lumps that are hard. And when you feel something like that, you kind of know it. We have detected cancers that way. We're recommending screening MSM and transgender people at the age of 35 and older, and women and others for over the age of 45 years. But that's only if you have the ability or to do HRA yourself or to refer for it. If you don't, then please just do the digital anorectal exam and get started in doing these techniques and learning how to do them. For now, at least, we're still in early stages, but we're recommending a combination of cytology and HPV testing, similar to what's done in the cervix. Other implications are that there is still room for improvement in treatment. We'd like to get the cancer rates even lower as a result of treatment of anal HSIL. And with so much HSIL and so little capacity to do it, there's so few people currently trained in HRA, we really need to know who we need to focus on, and biomarkers of progression, I think, will be really critical to allow us to focus on those individuals and perhaps spend fewer resources on people less likely to progress. So what about the Asia-Pacific region? If you'd asked me a few years ago, I would have said we're over here, but now we can move this way. I like going to the left since I'm a left-handed person, and we need to be thinking very seriously about ramping up training, screening, and treatment. In my mind, the two biggest priorities right now for the Asia-Pacific region should be to ensure robust collection of anal cancer data, particularly in the setting of an HIV match. I think what tends to get policymakers' attention is rates of cancer. And we really need to know what the cancer rates are in people living with HIV, and I don't think we have enough information on that quite yet. We also need to ramp up our training programs, because none of this is possible unless people know how to do high-resolution anoscopy. There's a great group here in Bangkok, but they can't do everything themselves. And there are great groups in Indonesia and Malaysia and some of the other countries as part of ANCRE, but again, they can't take care of an entire country. So with the decision to ramp up the training programs, there are a number of steps that are involved. The first is to find the right people. This is a labor of love. It's a really interesting thing to do, but you have to really be dedicated to it. You need to have the right equipment, because if you don't have the right equipment, everything else is moot. And it has to be installed in the right environment. It's important to get very thorough training, including didactics, and the International Anal Neoplasia Society offers an online course, which I would strongly recommend. I would also suggest that people establish connections with international experts for mentoring. This is like the cervical model. It's very important to learn to recognize and biopsy HSIL and cancer, and also to know when to refer for treatment. So there's a couple of benefits here. Using the newly acquired HRA skills that people will have, they can identify the folks who really need to be treated now that we know the treatment works to prevent progression to cancer. But there are also some great research opportunities to define the current prevalence and incidence of anal HSIL and to work on screening algorithms that are appropriate for this setting and biomarkers of HSIL progression and regression that are appropriate for this setting. And then from a treatment point of view, very important to get folks treated, but again, there are terrific research opportunities. As I mentioned, improving treatment is a high priority, and I think there's an awful lot to learn and do, particularly for things that may be especially appropriate for local settings. So I just want to close by showing you the last slide of that 2015 presentation. I kind of chuckled when I went back to it after I prepared this presentation, because that last slide had a bunch of recommendations too. It said improve vaccine delivery. That's a whole other topic, very, very important. And when I say vaccine, I mean the HPV vaccine. Collect the cancer data, train clinicians to collect the HSIL data, and do the research needed to define the future scope of the problem. Well, the future is here now. We're now in the post-ANCRE era, and I'm so pleased to be here because I'm really hoping that this will serve as a call for people to really take this problem seriously and get ahead of the curve rather than waiting for cancer rates to go up substantially in the coming years. So I'm going to also conclude by thanking the very many people that participated in the study and my colleagues at ANCEP. I'm very grateful for your attention. Thank you.